Hello, everybody. My name is Dan Gerard, and I'm the EMS coordinator for the City of Alameda Fire Department. First, I want to start by saying that I am not an expert in behavioral health response, but I know what I don't know. As an EMT, as a paramedic, and as a registered nurse, I realize what my education limitations are. EMT and paramedic behavioral health education in the United States is essentially limited to about 20 to 30 pages in any EMT or paramedic textbook, with about 2 to 4 hours worth of classroom education and no clinical time or no clinical education. Compared with licensed clinical social workers, licensed clinical therapists, psychologists, psychiatrists, they are better prepared to enter the realm of crisis mobile response. And with that, they're also provided with the mental health resilience training and protection that is so crucial to their ability to operate in this environment. Unfortunately, in the EMS world, we do a poor job in this regards. Legislation that has been promulgated across the United States to stand up 988 systems, to stand up crisis mobile systems, says that we need education specific to our discipline in order to operate effectively. An organization came to my attention that they were struggling with providers within their system. When they first stood up their program, they did an outstanding job of providing care in their community. And it's truly due to their dedication and compassion that the program was a success. But in the first 6 months of the program, this was related to me by this organization that half their members wanted to quit the program, and one member actually did. And one of the things that was missing from their training was mental health training, how to protect themselves. This is something that people in the behavioral health community, it is part of their dynamic, it is part of their world. When you're deep dived a little bit deeper into their training, things like diversity training, addiction training, how to assist people that are deaf or may have some other challenge that may make it difficult to communicate. I was reminded of a situation that happened in Southern California of a deaf patient that had a meth substance use issue that was also schizophrenic. And there was almost a near tragic outcome with that individual. What are we trying to accomplish? As I started to look around, what were the baselines? Who was out here in this space providing this training? I work with the Co-Responder National Consortium. I've been working with them for the last 4 years. I was invited back to DC to work with Georgetown, the Center for Community Initiatives, and the New York Policing Alternative Institute, and speaking with people from around the country. Chicago Fire provides 180 hours of training for their basic EMTs and their crisis mobile unit. Washington, D.C. provides 260 hours for their crisis mobile teams. Atlanta, 280 hours worth of training. I don't know what the number is, and I don't know what it needs to look like, but organizations need to do needs assessments and gap analysis in order to do that. And to my amazement, Joseph Burgandy read an article that I wrote, and a door opened, and there was an opportunity for us to work together. Joseph has been operating in this space for an incredible period of time. He has experience as a paramedic. He has experience in a pre-hospital care environment. He was a paramedic, he was a fire captain and oversaw the paramedic service for a department in Texas. He's a licensed clinical therapist. He has a retinue of patients that he provides care to, and he's been operating in the mobile crisis realm for an extremely long period of time. And I'm really condensing a lot about Joseph down into a couple of seconds, but he's really one of the experts in this field in regards to providing education. His program is unique in that you don't have to adopt the whole thing. If you have parts and pieces of your program that you're satisfied with, he has modules that you can insert and make your program better. But he is a good person. I wanted to bring him here and let as many people as they can hear about his program, hear about the work that he's doing, and explore the opportunity to see what he has to offer. And even if you don't work with Joseph, even if you don't adopt anything from his program, you may turn around and look at what you're doing differently and do a better job with what you're doing. Without further ado, please, Joseph Burgandy.
Thank you, Dan, for that warm introduction. It was an honor and a privilege to be invited here today. I'm very glad to share our time together to talk about the First Responder Behavioral Health Institute and to go ahead and talk about our programs. And let me go ahead and let you know that during this live stream, we are going to go ahead and take questions. And I'll bring up that several points during the live stream. We're going to go ahead and take questions, so please feel free to go ahead and comment and question, and we'll go ahead and include those as we can into our discussion. If you want to ask a question, please put the letter Q in the front of it, and we'll go ahead and we'll try to bring that to the top, and I'll try to answer questions for agencies. My apologies for the technical glitches this morning in getting us launched. We had over 110 people signed up to hear about mobile integration of healthcare, which says a lot. It lets us know how much need is out there and how much the paradigm is starting to shift in that direction, which is a wonderful thing. Let me get our slide deck going, and we'll go ahead and press forward with that. So the First Responder Behavioral Health Institute, our presentation and our courses on mobile integration of healthcare. We have 2 tracks of training, and we'll discuss that. First, let me tell you where we're based. We're based in Texas, and our headquarters is in Fort Worth. You can get a hold of us on our website at any time to check out our classes and our faculty at frbhi.com. Let me tell you a little bit about myself and what got me into this work. I have, as you can see, I'm a man who wears many hats. There you have it. I am the founder and program director of the First Responder Behavioral Health Institute. I am also, as Dan said, a licensed clinical counselor and a partner in the Counseling Center of Texas, which has been operational since 2014. We have a half a dozen therapists, and we work statewide. I'm licensed as a therapist in Texas, Washington, Oregon, and California. I also run a crisis response team, and that crisis response team works for first responder agencies, police and fire departments and EMS agencies, and it is staffed with clinical therapists, and what we do is we work on the EMS and fire side, police side, and we go ahead and work with line of duty deaths and provide critical incident stress debriefings, come out to homicides and to drownings, mass casualty incidents, and things of that nature. So this specific unit is tailored in its services to the first responder community. And its reasons for that are the reasons the Institute was created. But let me go ahead and go down the list a little bit more. I'm an EMS coordinator in the state of Texas and qualified to teach the EMT programs, and often do as an EMS instructor. This all started for me at the age of 17. I was an EMT at 17, a paramedic at 21, and have over 35 years of first responder experience. And in California, one of the opportunities I had to serve was not only as a first responder in the Bay Area, but also working in hospital with San Francisco General and University of California, San Francisco Medical Center. By the way, I'm also K-12 certified as a school counselor and run that program as well. So why did the Institute come to be and what is the Institute? Let me make a case for it. First, we're a 501c3 nonprofit organization. And it is a passion of mine to go ahead and improve the first responder community and deal with some of our biggest issues. So we are an evidence-based institution, data-driven, and I'll talk a lot about that in a moment. We use a Richard Branson model in our leadership. We train our faculty and our members so well they could leave us at any time, and we treat them so well they wouldn't want to do that. We're always seeking collaborative relationships with organizations and partners. We don't believe in competition, we believe in collaboration. That's why we are a nonprofit organization. So this is all about the quality of the instruction and the depth of the instructor. The Institute competes against problems, not against people and other organizations. We hope that you'll consider taking our courses and looking at what we have to offer, but we also recommend people in this space who do great work that don't work with us. The International Critical Incident Stress Foundation does outstanding work, and we have a couple of their faculty on our faculty to teach their courses as well as ours. So we don't recreate the wheel, we partner with good courses and good things that are happening, and we try to expand upon them. And then we design original courses and original solutions to the problems you're facing. Today's problem, mobile integration of healthcare, is a big issue, and we want to go ahead and address that competently and collectively. So why the Institute? Why was it created? The First Responder Behavioral Health Institute was created because we were trying to get to the bottom of first responder suicide. It is an absolute epidemic, and anyone in this space and in this community knows that it is. By the way, at the end of this lecture, I include a toolkit for all agencies with a lot of research that'll enable you and empower you to address your stakeholders. One of them is the Rudderman Report, which Def Dill over at Firefighter Behavioral Health Alliance did in cooperation with other agencies. And this goes ahead and states the depth and the level of problem of suicidality. Having been a first responder for 35 plus years and having lost 3 to 5 colleagues each year over those 35 years, in many conferences I speak at with 150 to 200 people in the room, I've actually experienced more suicide in my career than I have members attending my lectures. So it's been near and dear to my heart, and I wanted to go ahead and address that. And doing so, my career transitioned, and I went back and got a master's in clinical mental health counseling and became a complex trauma and traumatic-related disassociation specialist. And then returned to the first responder community and served for about 8 years recently with the fire department in Dallas, created the crisis response team, and got us out there working in the community with first responders and agencies. And that transition, we ended up taking about 25 to 30 calls a year on the crisis response team, and 80% of those were out of district. We were mutual aiding. At a certain point, it made sense to leave the fire department and bring that crisis response team into the Counseling Center of Texas. And now that crisis response team has been moved into the First Responder Behavioral Health Institute, and we're growing it because the need is there and we're trying to address a serious problem in our community. First responder suicidality and the lack of behavioral health knowledge in the first responder community is the fundamental reason we founded this institute. As Dan had said, and it has been my experience as an EMT and paramedic instructor, every textbook out there has 0 pages about how to take care of yourself. At least in registered nursing programs, they're getting 1 to 2 psychology courses and a nutrition course, and that's not nearly enough. But when it comes to our paramedics and that level of curriculum, there is no training on self-care, period. and a sentence. So, and then we go ahead and we deal with how we respond to a community in crisis. We recognize that our statistics are quite clear. 80% of the modern day fire service is responding to medical calls. Of those medical calls, 35 to 45% of those medical calls in any jurisdiction are behavioral health based. And I had colleagues challenge me on this, and I'll say, listen, when we sit there and we look at the statistics, you might actually have more than one category this falls in. You do indeed have a car wreck. You do have a car on its side. You do have trauma. But also at the wheel was someone who was driving drunk. You have a substance abuse issue on your hands. You have somebody who is self-medicating. Why? There's a mental health component behind that and behind the reason they're behind the wheel in such pain. So half the time we don't statistically categorize these calls correctly or recognize the behavioral health component when we strap on a 12 lead or 15 lead and we see that somebody is not having a heart attack and recognize it is indeed anxiety, panic manifesting in the body in a similar fashion with shortness of breath and all the other issues that we see clinically when we're in the field. So we have no real training on behavioral health emergencies and how to go ahead and treat them. As a matter of fact, the pages in a paramedic manual, a whole 30 pages max in most manuals, half of those pages are about physical restraint of the patient and the other half is about chemical restraint of the patient and a little bit of documentation. Nothing about de-escalation, nothing about signs and symptoms of schizophrenia, psychosis, and working with the various disorders. So this training simply isn't in that curriculum. And then the final reason that the Institute was created was to go ahead and help with organizational development, because we recognize very clearly in the clinical suite when I have first responders that are in crisis and are suicidal, there's 2 or 3 things at play. One, the psychology of the self. They have never defined what a healthy me looks like. 2, there's the call that snapped them, that brought them in for services. And oftentimes, 3, there's an organizational development piece. The administration and leadership does not know how to handle a behavioral-based emergency or a first responder in crisis. We have all sorts of operational manuals and procedures to take care of our first responders after they have suffered a work-related injury, a broken leg, smoke inhalation. We have occupational therapy. We have physical therapy. We have all sorts of protocols written. But when it comes to a member who is suffering from addiction, a member who's having a behavioral-related crisis themselves, most policy and procedure manuals have nothing in it. So we can also imagine very quickly if we don't have anything in there, it's questionable the kind of help they're going to get. Some leaders really take this to heart and they're there for their members. Others don't know what to do and they back off at the wrong time and leave the member isolated, especially in organizations that are first responder based, where we go ahead and we use terms like family and that you're a member and that you're part of our bigger community. And if you break your leg, we're here for you. But if you saw a call that caused traumatic related stress, we don't know what to do. One of the other messages I'm here to deliver, being a complex trauma specialist, is most post-traumatic injuries are recoverable, especially if we get to them in the early part of the diagnosis. And the return to work is highly probable. And that's one of the things that we want to educate our leadership to. We're doing just that, and the Institute was born out of those things, out of those elements of a desire to continue service and to treat our members. So we're evidence-based, data-driven, and we seek to redefine the status quo. That's one of the reasons that we're privileged to have Dr. Ian Mosher on our faculty, and he's amazing with data. Some of you have taken his many surveys he sent out. So we design curriculum and provide education in 3 areas. The psychology of the healthy first responder, area 1. 2, working with the public in crisis, how to understand that, de-escalation training, other training of that type. 3, the organizational development and leadership development piece. Now, in keeping with that, what we have done is we have created 2 clinical pathways. And I probably should have mentioned starting in that I have 2 master's degrees. One of them is in education and curriculum design, and the other one is in clinical mental health with the specializations that I had mentioned earlier. So while I was sitting there trying to solve the problem of first responder suicidality, I came to really sit with this issue and realize the depth of it. It is not only the unhealthy first responder and that they're not getting the care they need, they don't have the education. We're not handling the public well because we haven't had the training and the organizational development piece. This is not going to solve overnight. So what I did when I decided to put the program together was created 2 clinical pathways. By the way, you can take any single course on our platform. You do not have to sign up for all of our training. It is our hope, once you realize the quality of the faculty we have assembled, that you'll consider going ahead and taking another class, and before you know it, you'll be past 500 hours over a couple of years, and then you'll be able to sit for the certification as a behavioral health first responder or a behavioral health clinical responder. These are trademark terms of the Institute, and in order to go ahead and sit for that examination, you're looking at a couple of years. Now, when you look at the community paramedic programs, most of those are about 600 hours or more of training. When you look at other programs of like type. So ours is modeled after that. But we just want you to get in, take a 1 or 2 day course, take a half-day course, see if we have what you're looking for, and hopefully you'll stick around for a couple of years and you'll go ahead and get the training. So if you're a behavioral health first responder, EMTs, firefighters, paramedics, and people of this class, we have a whole litany of training, dozens of instructors and courses, which I'll tell you about, including mobile integrated healthcare. Behavioral health clinical responder is for the counselors, therapists, psychologists, and physicians and nurses that we're working with, because as I assembled my first crisis response team and my medical director said, we need you out here for a debriefing. We've had, a 5-person fatality. We've got 40 members. They're suffering. They're in pain. What can you do for us? I said, I'm going to call everybody and we'll be right there. And I went ahead and made that phone call. Out of the 30 clinicians I spoke to, 25 of them said, I'm not trained to do this. I can't help you. The 5 that remained, a couple of them were out of town. The other 3 went with me, and they're still on my crisis response team today. And I recognized very quickly that we have a lot of great clinical skill that we learn in our training, but stepping into a field-based environment, having the cultural competency to work with a first responder community is not part of our training. So that's when I realized we needed to step that up, and I came up with 2 clinical pathways. Now we're seeing that paradigm shift. Now we're seeing co-responders get out there in the community, and clinicians are desirous to learn how to do this, do it properly, do it effectively. So paradigms are shifting. And this is kind of where we're at. We've hit the pioneers. All of you that are currently running co-responder community programs of any type, you are pioneers. And now we're sitting into the early majority phase, and we're getting ready to go over the hill here, where we're going to go ahead and have some standardization and regular curriculums, and people are starting to go ahead and talk about that and trying to implement that. So the evidence is surrounding mobile crisis response teams is compelling. And according to the National Alliance of Mental Health, a recent survey, it has been shown that nearly 85% of the people who interact with a mobile crisis response team and have an intervention avoid hospitalization. Also, people who become disconnected from their mental health services are much more likely to re-engage that service after having had contact with a mobile crisis team. Especially true for depression, mood disorders, psychotic disorders, and that just came out of NAMI. We know that there's a lot of different programs, and they're under a lot of different names. Mobile integrated healthcare will often be a term that is used to describe a community paramedic program. Sometimes it's used to describe these other things. Mobile integrated healthcare, mobile crisis response team, mobile crisis outreach. Apparently, if you're in Oregon in 2 cities, it's not statewide. There's a CAHOOTS program. I thought that was a game I played when I was a kid, but it stands for Crisis Assistance Helping Out on the Streets. If you are in Oregon in only 2 or 3 cities, and that model does not use law enforcement at all. You know, the models are coming, all these models have different forms of, team makeup, and we discussed that in our training. So community mobile response teams, the Right Care program, which one of our faculty and the principal designer of the mobile integrated healthcare program for the Institute is also one of the people who designed Right Care. And Right Care stands for Rapid Integrated Group Healthcare Team, and that is run by Dallas Fire Rescue. Deputy Chief Tammy Kaye put that program together. That program has gone from 4 units, they're adding 8 more units this year, and it consists of an unmarked vehicle, usually a Tahoe, and they have a police officer, a mental health professional, and a paramedic, often in plain clothes with ID cards. So they go ahead and respond to these situations in the community and add value. By the way, apparently, and I just found out about the International Co-Responder Alliance, I guess they're in their 4th year of doing conferences. I hope to go 1 year. So it's National Co-Responder and Crisis Responder Week last week. So we are getting somewhere and we are making a difference. I hope you're going to mention the care team in the city where you're standing right now. I am mentioning the care team in the city I'm standing right now. Dan, what's the name of the care team in the city I'm standing right now?
It's the Alameda Care Team.
It's the Alameda Care Team. Jonathan, thank you, and thank you for mentioning it. I just saw it on the comments. I appreciate your input and going ahead and giving us that. Nick Luby, Dan Gerard. Thank you, Jonathan. So they're very good, very good. So what we're seeing here is certainly a rose by any other name. It is a program that is needing to be rolled out. I don't care what you call it. I just care that you do something with it and you add some value to your community and make a difference and continue doing so. So how do we provide behavioral health services when it's simply not included in our training? That is the issue we're trying to go ahead and get to. Communities that have engaged a community mobile response see a return on investment. Sometimes that's financial, but that's not the goal. The goal is to keep people who engage these systems end up not in jail and in custody. They end up out of the hospital. And one thing that is a certainty that has been spoken many a time is that the services are non-existent in an emergency department. Any emergency room physician hearing this message will agree with me that there simply are no services available in emergency departments. So to divert that and to keep that service out of the emergency room and to keep them available, and more importantly, as we're working in a 911 system on the streets, I know the frustration personally of having a level 1 trauma call go down 3 blocks away, and I'm with a less acuity patient who does not need 911 services, but we were the only person they could call. And then 20 minutes away, another unit is responding to a pediatric drowning while I'm dealing with somebody who's having an anxiety, panic disorder issue, or having a homelessness situation and needing referral of services. Those are important calls. Not to say they're not, but when they're taking up valuable 911 resources and we're not able to go ahead and meet the need, that's an issue that does cost lives. Clogged up emergency rooms and not having people available when needed, those are issues that cost us in resources as well. Now, if you'll go ahead and click on the Mobile Integrated Healthcare QR code right there, I'll bring it up in a moment, but this will give you our faculty and the people who were instrumental in helping us to put this program together. So let me go ahead and do that, and I will take us to the next page so we can do that. I'm going to give you another few seconds. Anyone on the comments, please don't hesitate. I can see you. What you're saying there. I see who's playing around with my computer. Oh, my goodness. All right. So that's going to get challenging. So, the mobile integrated healthcare team, let me take over that. All right, and I just want to draw your attention to, here's some of the points that we cover in our training. Prioritization of calls, clearance, paramedic issues, clearance issues, targeted violence prevention. Which program are you running? What kind of co-responder model are you choosing? EMT, paramedic clinician, paramedic police officer, virtual clinician, clinical responder, peer support, and our design team. Deputy Chief Tammy Kaye at Dallas Fire Rescue is one of the principal architects of the First Responder Behavioral Health Institute Mobile Integrated Healthcare Team. 28-year veteran of the department, and has been an architect of their Right Care program, and has a leadership background that is second to none. We fall under the medical direction of Dr. Eric Perlman. He was kind enough to follow me into the Institute and has been my medical director for about 8 years when I was working 911 and doing crisis response work and the mobile crisis response team that we run for departments. And he's been an advocate. He's also still a paramedic and keeps his licenses current. Courtney Tassin is a licensed professional counselor and a program director for the city of Aurora, and develops co-responder programs and does a lot of training for agencies as well, and has one of the most well-developed programs that we've ever seen. So with Courtney's help and Tammy coming together to design this curriculum and put it on its feet, and it speaks to the caliber of faculty that we use at the Institute. Our faculty, we try to get the very best in people who are actively doing the job. We're not an academic institution where a textbook we're writing is 6 or 8 years out of date before it's written. Our modules are being done in real time. Our people are solving problems in real time, and they're often out in the field doing the work now. Measurement is very, very important to us, and we are privileged. If you have not taken a survey from Dr. Ian Mosher, you're probably not providing mobile integrated healthcare. It was part of his dissertation for his PhD, and he wanted to answer the question of, basically, why are there issues with care for populations that are suffering? And once I spoke to him and got a chance to listen to his passion, I realized we needed him at the Institute. Because the reason we're suffering at providing quality care in the first responder environment is because we simply lack the training. And his surveys have helped agencies to recognize that, and he writes a bunch of surveys for us anytime we're called by an agency to go ahead and help. And I'll go ahead and discuss our accreditation a little bit later. We are accredited. And let me move us back to the slide deck here and hit the right button and give you a second to hit that QR code. And let me move us forward. All right, so 2 learning pathways, 3 levels of instruction. The first pathway is the first responder. The next one is the agency's administrator. All right, so first responder level 1 training. We go ahead and talk about the definition of mental health. And by the way, the first level of training is a 3-hour program. We can do it in person or online. And this one is designed for everyone in the agency. We realize that if we're going to get people on board, we need them to go ahead and have everybody on board. So we designed that module, and here are some of the things it covers. Safety assessment, what is a mental health versus a medical emergency? And how do we go ahead and reclassify our patient to a client? And how do we get that transition of care handled so they can potentially be transported differently? Specific populations, children, adult, homeless, veterans, and special needs groups. Basics of de-escalating crisis intervention. and alternative destinations of transportation. As we said earlier, there is no service in the emergency department. New response trends and models. How do you study and know that your program's being effective? Utilizing the available support agencies. So that's our level 1 training, and that is a training module we put together in person or online. We love to do them in person, and we have a half-day and full-day program for that. Our online program, 3 hours with learning modules and tests, and we put it at a very low cost point so that every agency member could afford it. So this is about us getting this knowledge out there and making a difference, not making money. All right, level 2 training. This is going to be for members of the team you're onboarding, and this is going to be mental health agencies around you, goals and objectives. What's the mission of yours? What model's been selected? What stakeholders of the new system are requiring of you? What are the roles and expectations? What are your current protocols? What protocols need to be developed? That's another thing that we excel at, is helping agencies develop new protocols. What laws, regulations, and ordinances might need to be changed? How do we adjust our response plan? And that's part of our level 2. Additional level 2 training. And I'm going to have to take a moment to play with the power on my laptop and adjust my microphone. So. Okay, very good. All right, so now we got our audio back. My apologies for that little delay there. And let's continue. All right, so onboarding of new members, going ahead and getting them the basic training together that they need. This class covers documentation, special needs, and we also look at your local documentation needs, right? What are they? What are you needing us to go ahead and help you with? What is already working for you? What needs to be changed? All right, team building. One of the things that we found, and Chief Kaye found, was one of the biggest issues that she was facing was understanding work cultures and how all your other partners in other organizations understand their role. Applicable laws and requirements of each agency and the rules and goals of effective communication between these agency players. So, all right, let me hit the next slide. Okay. All right. So this is level 2 is a 3-day instructor-driven course, 24 hours of training, and we are very, very aware of your needs when it comes to training and budgetary considerations. So we can come in and we can do that training in 3 days, or what is most often the case is that might be done 1 day a month for 3 months, and they might do it 2 hours a day, 1 day a week. So that 8 hours of training comes in over a month. Then we'll do day 2 the next month, day 3 the third month. Because we've got to be aware of the overtime we can create with training programs. I've been a training officer for a long time. I understand our budgets and our overtime considerations. So if we have to stretch a 3-day training into 3 months, we're prepared to do that. So we work with your needs. Level 3, Advanced De-Escalation and Crisis Intervention Training Program. Efficiency metrics. How do you measure it? How do you know you're being successful? What's the community engagement like? How do we handle welfare checks, follow-ups in the system? What are the strengths and weaknesses of your assessments? Team building and more system expansion considerations. That's an additional 1-day instructor-driven program, 8 hours of study, taught in the classroom or taught online in combination. So for the first responder, we're essentially at a 40-hour program of basic level instruction. And then we get to the agency's administrator. We recognize your time is extremely valuable, but you also have to have all players able to hear what you're doing and know where they're supposed to be on this. And for that, we're covering similar things: goals, objectives, system requirements, your legal, political, community issues, laws, regulations, funding, budget, grants, stakeholders and community partners, and new response trends and models. And that as well, a 3-hour program of training available in person or online, or a half-day, full-day program that we were happy to come out and present at a very low cost, $30 for the module. And this is something we want to go ahead and offer to show what we're capable of and also to help agencies in needs. So the next one is a 1-day program for agency administrators, medical directors, and your program officers, talking about staffing, transportation, dispatch, equipment technology, protocols, guidelines, agency policy and procedures documentation, and different regulations, measurement, metrics, and reporting. The next one is our 1-day instructor-driven 8-hour program for administrators. Let's see, that's still on level 2. Level 3, social and news media, welfare checks, advanced de-escalation, and program efficiency metrics. A lot of the administrator stuff is about metrics, measurement, community engagement, engaging city council, engaging your stakeholders, and the community to get the buy-in you need. And that is as well a 1-day program of instruction. One of the things we excel at is customization. We have curriculum design experts on our faculty. And as we know in the U.S., if you've seen one EMS system, you've seen one EMS system. So we are completely customized, tailored solutions with our client partners. We do it in person, we do it online, and we do it in a hybrid format. Nothing could be more true than this example when doing mobile integrated healthcare. In California, it's a 5150. In Colorado, it's an M1. In Arizona, it's a Title 36. And in the great state of Texas, it's an APOW, the arrest by a police officer without a warrant. All of them are very similarly written statutes with some different caveats that have to be taken into consideration for implementation with the local community, preferably in association with your medical director, to go ahead and make sure that we're hitting all the guides and that we're doing it right. When we involuntarily incarcerate someone and take them into a facility, we're taking their civil rights away. We want to be very cognizant of this and make sure that we have the very best training and that we're going slow and that we're using de-escalation. Yes, Dan. Absolutely. What Dana just asked that question was about what if we have specific needs in our community? One of those needs might be substance abuse issues. And can you help build that out in a customized format for us? The answer is absolutely. And my first go-to is a member of our faculty called Sherry McKesson. Sherry is a 15-year police officer. She is also a licensed professional counselor, trains on EMDR 1 and 2. She does our addictions courses. She has an addictions module that she offers for first responders and an addictions course she offers for our clinical therapists, as well as teaching EMDR 1 and 2 for us. So Sherry would be my go-to consultant that I would bring in and say, this community is having this specific need. You're already teaching these addictions courses for the Institute. Help me tailor our curriculum with Mark Hill, with Christine Johnson, to go ahead and come up with the learning objectives needed to where we can offer that effectively and in a customized format with your people. Yeah.
So I just want to follow up. So essentially, what many of us in California are dealing with is that when behavioral health providers have to provide training, what they're really doing is providing the continuing education programs that they provide for the licensed clinical social workers.
Yeah.
And it's not address, it doesn't address the needs of EMS providers. So realistically, what they're giving us is scaffolding of
Yeah.
programs, and there's no congruence.
Yeah.
And congruence is essential to this entire process. So if we had to build, so after we do our needs assessment, and then we conduct our gap analysis, there will be congruence from not only your 40 hours of instruction, but whatever else we need to build into that. So if we need to talk about the undomiciled, if we need to let people with substance issues, etc., and how it affects different disorders, whatever we need, there'll be that congruence, that natural transition, so that each part goes back and forth in each section. You know, the scaffolding sort of thing that we're trying to figure out.
I'm glad you said that. And for those that didn't hear Dan's question, he's talking about congruency of courses and the fact that many times when they're receiving training from addictions, it's often borrowed from CEUs, from social worker programs, and things of this nature. Our answer to that is to bring a police officer therapist into the room. Our answer to that is to continue to be in the first responder community to where our faculty is had boots on the ground most of their life and can go ahead and address this and can keep this training relevant to first responders and not just something that's been borrowed curriculum from another discipline and hasn't had the vetting and isn't going to stand up the way you're wanting it to stand up when we're in the field. So, good. Great question. Thank you. And if I didn't answer it, let me know. I'll go deeper. But thank you. All right. So that is a thing, you know. Then that's why I use this as an example, because it's a critical area. Taking somebody's civil liberties away should never be taken lightly, and it's going to be an area of law where you're going to have to custom tweak your response. It should be a last resort item, but you've got to know de-escalation training. You've got to have other things in your toolkit, or people will resort to this. Our faculty, the people I'm talking about, our current demographic is 1 medical doctor, 5 PhDs, 11 master's degrees, 3 registered nurses, 12 paramedics, 7 firefighters, and 3 police officers currently make up the First Responder Behavioral Health Institute. These numbers represent less than half of our faculty and half of our courses, because the only way you get your number on this list is if we've already moved your course through to where we've got the learning objectives where we need to be, and you're potentially already teaching it somewhere else. So these are people who came together recognizing that sharing a common platform, and all of them are experts, many of them are published authors, and they recognize they could do more by coming together and working collectively as a group, and they wanted to see the movement towards the bigger picture and the shifting of a paradigm. When it comes to accreditation currently, we are accredited by the Texas State Department of Health Services for CE programs. We're also seeking application, and I make no promises when it comes to accreditation bodies. However, we're in the process of applying to the PCE, ACCME, and what those will do is help us to be coast to coast. However, we apply for local accreditation everywhere we go. Our California programs are accredited immediately for use, even though we don't have to be. According to the Coordinating Board for Emergency Medical Services, CE programs approved in other states do not have to be approved in California. We don't care. We always seek to rise to the higher standard. And so we have structured a relationship with Snowy River EMS, and we're privileged to say that right now, today, our programs are available for local California accreditation for our first responders and for the Board of Registered Nurses. So, and in any state that's watching this, we will reach out to your local accreditation agency as well to help, and especially until our national accreditations come in. Let me talk a little bit about the faculty that I'm bringing to the Institute. You've been suffering through me for almost an hour. I apologize. And I told you my background. Mark Hill, firefighter paramedic, master's degree in education, the author of 2 Dark 30. He's also been a principal of a middle school. And we also have a podcast. If you haven't caught En Route, the podcast of the Behavioral Health Institute, please do. He answers a question for me there, which is a more challenging group, middle schoolers or firefighters, to be in charge of. I'll let you watch the episode to go ahead and find out the answer to that. But Mark brings an enormous amount of background and skill to our institute. The next is Dr. Kwame Scruggs. Kwame is got his PhD in mythology of all things, but he adds so much value to the institute because his work on nonprofits exceeds 20 years. He's on the has his own nonprofit, Alchemy, which works with inner city youth. And his programs, I have had the privilege of having him write a special curriculum for our first responders, and it has done great things. We rolled it out in 2019 before COVID took it out, and we're getting ready to offer it again. He's also on the board of directors of Joseph Campbell Foundation, if you are familiar with it. The guy on the end is Dr. Roger Solomon. Roger is former police psychologist of over 20 years. Roger's on the board of directors of EMDR International. He is a consultant to the United States Senate, the National Aeronautics and Space Administration. He's trained for the Secret Service, the FBI, and the Italian State Police. He's also been to the Ukraine during the war, teaching EMDR to clinicians in war zones. And he's a mentor of mine. He's a complex disassociations expert, and I benefit from him and his wisdom all the time. Here are some of the players and some of the people who have been adding value, deciding to throw their voices behind the Institute and hoping to go ahead and shift our paradigm for change. Deputy Chief Kaye from Dallas Fire Rescue was the person in charge of our curriculum for mobile integrated healthcare, shored up by Courtney Tassin on the other end with Aurora, City of Aurora. I'll just go across the top row really quick. Mark Bouchard. Mark is a paramedic and a police officer with the Royal Canadian Mounted Police, and just wrote the book, Setting My Sights on Stigma, Thoughts from an Injured Mind. He is recovered fully from a PTSD diagnosis and is now a wellness officer within the RCMP. Dwight Polk is a therapist and runs Free State Behavioral Health. He has also spent 30 years as the paramedic instructor and coordinator department chair for University of Baltimore, Maryland's paramedic program. He was an architect of the community paramedic program. Temper Sherrill, paramedic and licensed professional counselor, and runs the Brave Fight in Fort Worth, a great unit. Nick Arnett on the bottom left. And Nick is with CAL FIRE and is actually on a fire assignment, or he'd be here today. He's in the Bay Area. He's written 2 books on resilience. One of the other issues we find with our first responders is they haven't had training in resilience. So how do they get that? Nick has 2 courses on the platform that he offers. The other guy, doesn't he look like a SWAT team commander? That's Chris Davis. Chris is indeed an assistant police chief, retired, but he is also the guy who teaches our yoga and our mindfulness and meditation courses. His company is Yoga 911. Please reach out to them. He is in the 20-minute interview I had done with him about a month and a half ago when we brought him on. He lowered my blood pressure about 15 points in 15 minutes. He is just such a calming force and has so much to say, and meditation, mindfulness, yoga, but also leadership development within law enforcement agencies. Ian Mosier, Dr. Mosier is here with me today and did his dissertation on mobile integration healthcare, and we trust him to keep us, him and Tammy Kaye, to keep us evidence-based and data-driven. Daniel Sundahl, most of you do not know him by name, but you know him by his artwork. Daniel's got 4 books out, and his artwork has changed the face of emergency medicine, the fire service, and police departments. He is a firefighter paramedic out of Leduc, Canada, and he has a 3-hour resiliency program that he teaches on our platform. And Sherry McKesson is the police officer, licensed professional counselor, and addictions instructor that I mentioned earlier when Dan asked that question. So, let's see, nope, go back here. All right. Let me get all my buttons to work today, and I want to apologize for all the technical issues that we've had today. And go ahead and boom. All right. So the toolkit, I'm going to leave that up for a minute, and I encourage all of you to click on that. I'm going to go ahead and tell you what's in your toolkit. What we want to do at the Institute is make sure that you get the resources you need to help move you forward. We don't care if you work with us. We don't believe we're the answer to every problem. We'd love it if you gave us a call and considered our experts and our many years of experience in what we're trying to do. But what we aim to do is to leave you better off than we found you. And I want you to be able to be an advocate within your agencies. So if you go to your toolkit, and I can get mine to stop moving around. There we go. The alternative crisis response programs lists over 100 of them. Community support programs, the brochure for this particular program. Assessing the impact of mobile crisis response teams. Wanted you to have that research and wanted you to be in a place where you can just simply go to the toolkit, print it off, and get to helping your agency do a better job. The outline of the mental health police officer curriculum for the state of Texas, a 3-day program which actually is really well done, and it is so much more training. If a police officer in Texas has taken this program, they actually have way more training in behavioral health emergencies than our firefighters and paramedics do. And here's the entire curriculum for you to look at your leisure, and to go ahead and see if there's parts of it that can help you. So the toolkit also goes into running a healthy agency, understanding PTSD, suicide, what a fire chief needs to know, how to ask questions, how to implement a psychologically safe fire department, the Rudderman report I mentioned on suicide, and our QR code if you want to figure out how to get a hold of us at the Institute to see if we can help you. The Institute is very easy to find. We are at frbhi.com. Let me just very quickly bring up our page and then talk. I've mentioned our faculty. And now if I can go ahead and get this thing to, thank you, magically. All right, so as I'm talking about our faculty, I've mentioned just a few of them. I couldn't get all of them on that initial list. Dr. Perlman, Christine Johnson, Roger Solomon, Dwight Pogue, our volunteer coordinator, Mark Hill, Ian. We've just got such an amazing array of faculty, and we've asked Dan Gerard to go ahead and help us with some leadership courses, Dr. Scruggs, and the list goes on and on. We're also putting the call out, we're looking for faculty. So if you have curriculum and you're trying to go ahead and make the world a better place in the first responder community, and you need help getting it implemented, come see us. Let our curriculum design people help you. Here's just a small list of some of the courses we put together. And I've been teaching these courses for years under the in the fire service and then over at the Counseling Center of Texas. The only thing that's happening is a change in the name. Mental health, suicide, and behavioral-based emergencies in the 911 system. I limit that to first responders, an 8-hour course. I can do it in a half day, a full day. Stress into Strength is based on Nick Arnett's book. Building Resilience, Turning Critical Incident Trauma into Strength, Roger Solomon's course. Mobile Integration of Healthcare, which is the reason I'm here today, levels 1, 2, and 3, for first responder or clinician. Knowledge of Self, The Search for Completion, Kwame Scruggs. Shaping Future Responders, Becoming an Effective Field Training Officer and Teacher. One of the hardest things to do in the fire service is learn how to teach. Being a training officer was difficult. Mark Bouchard's, this course is based on his book, Too Dark 30, and he has a companion workbook that goes with it. And we also offer school-based violence crisis response teams, crisis work, teaching school counselors the objectives of crisis counseling. Behavioral health clinical responder, level 1, 2, 3. Behavioral health first responder, level 1, 2, 3. Crisis response teams, how to set one up and what should it be doing when you do set it up. Police culture and lethal force decisions, part 1 and 2. That's Mark Bouchard's course, and that's based on setting my sights on stigma, thoughts from an injured mind. Mental health police officer, negotiations 1, 2, 3, workplace violence, EMDR. So as you can see, some of our courses are limited to clinicians. The gray courses, Roger Solomon's courses are clinician only in this area. And we also do leadership retreats if you want to get your team on track. Hostage negotiations, we have a couple of hostage negotiators that have agreed to teach advanced de-escalation. Post-traumatic growth, which is one Daniel Sundall's course does, and I teach a similar course. Peer support teams, 3 and 4 day programs, mental health resilience, and the list goes on and on. And this is less than half of the courses, this is less than half of the faculty of the First Responder Behavioral Health Institute. Every one of them are experts in their own. Every one of them are out there making a collective difference. When I called them and I tried to solve the problem and I realized I was calling them to get permission to use their books, permission to quote them, and to interview them. And each one I called said, I'll teach for you. I will go ahead and gladly join this faculty. Allow me to go ahead and be available. And they didn't have to be. So they recognize, as I started my conversation, by the fact that the paradigm is shifting, it is. And we're here. And we can change things collectively far easier than we can individually. Each one of these people are amazing individual contributors, and we use their books in our training. We use books of people who we don't have time. It's not only faculty based. If you're doing something great or another organization is, we want to tell people about you. We collaborate against the problems that affect us all. First responder suicidality. How we handle a public in crisis, and how do we educate our leadership and the best organizational development practices to go ahead and facilitate them making a difference in the workforce. That's what the Institute is about. That's why we created it. And, you know, that's why I'm here today. So, as I wrap up, I'm going to check and see if we have any questions. In the Facebook group, it looks like we're pretty clear. Thoughts and questions in the room? Anybody? All right. Should we go ahead and wrap it up? All right. Since we did have a break in the communication and everything, I want to let me switch screens. I want to go ahead and certainly apologize for the communications issues that we've had and let you know that we will clean this up and post it on our platforms for your consideration later. Thank you for joining us here today. For the First Responder Behavioral Health Institute, I'm Joseph Brigandi. Thank you.